Good afternoon. My name is Dr. Lee Schwamm, and I'll be speaking today about stroke system optimization. In 1996 through 2015, we had a unidimensional EMS triage system for acute stroke. If you were having a stroke, EMS only needed to take you to the nearest DPA-capable hospital. But all of that changed in 2015 with the proposal and then demonstration of benefit of endovascular thrombectomy. And now we have a complex and variable EMS triage algorithm for trying to decide whether to go to an acute stroke ready, a PSC, a thrombectomy capable stroke center, or a comprehensive stroke center. And this is a real dilemma. We know that there's limited US access to thrombolysis capable sites seen on the left-hand part of the slide by ground or air, and by contrast, EVT capable sites by ground EMS. So where you go for that first hospitalization makes a big difference. Until recently, all we had was from the American Heart Association, American Stroke Association, a pre-hospital routing algorithm that really struggled to be adapted to various environments depending on the level of capability, the availability of nearby stroke centers, and the different layers of this stroke system of care. So while the benefits of this algorithm are that it was relatively simple and actionable in some communities, for many it was too simple and not really actionable in a specific region, particularly one that contains multiple levels of stroke centers. So there was a clear need to update this protocol and really think about how to incorporate rural, suburban, and urban environments from the pre-hospital stroke system perspective. And that's what led to this consensus conference, which I was honored to help chair with my colleagues, Dr. Ed Yauk and Pete Penagos. And the following report reflects this consensus conference adopted by, as you can see, many of the leading national societies related to acute stroke therapy. We know from work in your very own Los Angeles County that there was a need for mechanical thrombectomy capability that did not rise to the level of a comprehensive stroke center for the treatment of subarachnoid hemorrhage and hemorrhagic stroke care, but was desperately needed in the areas shown here with red circles, which did not have accessible thrombectomy due to traffic and other geographic distributions to support what was still a very large volume of residents in that area. On the right-hand side of the screen, you see with probabilistic modeling how significantly the optimal choice of first destination can vary depending on stroke severity and the time it takes to get to the nearest stroke center. In purple, you can see when the scenario favors going to the comprehensive stroke center first versus in pink, the primary stroke center. So the longer it takes or the milder the severity, the more that favors pink or going to the primary stroke center first. The higher the severity or the further the travel time, the more the field shifts to purple. So really this is another way of explaining to the viewer that complexity must be accounted for in the algorithm. So the three big things to know are, number one, selected patients, but not all patients, with suspected stroke due to LVO should preferentially be triaged to the nearest EVT-capable stroke center. Local public health agencies, not certifying bodies and not hospitals, are the organizations best suited to determine the most appropriate acute stroke destination plans that are simple and balanced yet actionable. And lastly, guiding principles and recommendations for how to integrate these elements into a stroke system of care have to take into account three key regional settings: an urban, suburban, and rural setting, because of the different kinds of centers available and the population density involved. So for this consensus conference, we really chose to think about rural, suburban, and urban based on definitions that were objective, namely those of the US Census Bureau for rural-urban commuting codes. These RUCA codes demonstrate breakpoints as they relate to population density. And then we added in the concept of whether there was a nearby acute stroke ready or PSC hospital in the area and whether TSCs or CSCs would be available. And you can see here how as you move up the chain, you get more choices among resources. Lastly, I think the first destination that's most appropriate depends on the level of stroke severity, the degree of severity based on validated scales, not just EMT perspective or subjective measurement, and the availability of different levels of certified stroke centers. So the common principles included the following: that a region-specific system of care should be developed with local stakeholders, that destination plans, ideal plans are complex, nuanced, and have to factor in all the available data sources, like traffic patterns, site-specific performance data on frequency of use, timeliness of care. Regional destination plans should consider general eligibility for IV thrombolytics, and for those with suspected LVO within 24 hours of last known well, should prioritize a nearby CSC over other centers of lower capability if, and this is really important, if it can be done within acceptable transport times. That's really the key concept, and we'll show you that in some figures in a few moments. All members of the stroke system of care need to be engaged in public education around stroke risk factors, warning signs, and how to activate 911, because 911 stroke screening is critical. And public safety answering points need to utilize specific stroke screening protocols, not generic protocols, and send EMS out at the highest level for patients screening positive for acute stroke. We need to integrate regional EMS into the stroke system of care, so harmonize stroke management protocols, yearly education for providers. Agencies should develop and use, in conjunction with their state EMS and other hospital stakeholders, destination plans that are based on location, capability, transport time, and acuity. And they should use pre-hospital notification protocols to hospitals that are receiving the patients. There needs to be expertise in the emergency department, so hospitals should be prioritized that have ED staff who can assess and treat patients and have immediate access to stroke expertise, either on-site or via telemedicine. Advanced imaging is critical, and acute stroke-ready hospitals and PSCs should develop plans to implement CT or MR angiography in these selected patients with rapid interpretation on-site or via teleradiology. We need evidence-based inpatient stroke care, deeply coordinated interfacility transport so that door in, door out times are kept to a minimum if the hospital's not EVT capable, and rapid access to an appropriate level of care so care can be escalated. All this needs to be wrapped up in a coordinated quality improvement effort that includes all participating agencies and required data collection and reporting. So the different stroke center elements have been published before, and I just remind you here that the level of capability progresses as you move to the right side of this table, and that hemorrhagic stroke care is really the differentiator and neurocritical care expertise between the TSC and CSC. There are many potential measures that can be used for pre-hospital quality improvement, and here we list the 13 ones that are recommended in the paper, and they relate to things that you're familiar with already, like stroke screening and blood glucose and stroke severity, but also measures of timeliness of care. So in the urban environment, we recommend that when an LVO stroke is suspected and a CSC is within 30 minutes maximum transport time, you go directly to the CSC. Otherwise, directly to a TSC, and only if no TSC is available within that time window do you transport to the nearest PSC or ASRH. In the suburban region, if a comprehensive or thrombectomy stroke center is available within 45 minutes of maximum transport time, you go to the CSC unless it adds 30 additional minutes past the nearest TSC, and if not, to the nearest primary or acute stroke ready hospital. And then as we move even more further into the rural environment, if you can reach a CSC or TSC within 60 minutes, that's where you go. And again, you only go further for the CSC if it adds no more than 30 minutes, and you go to the nearest PSC unless it adds more than 30 minutes past the nearest acute stroke ready hospital. And if no stroke centers are available within 60 minutes by ground, you should consider air medical transport by your regional point of entry plan. I hope that this quick review of the approach that is outlined in the paper has stimulated some thinking and some conversation. I look forward to the question and answer period, and I hope that this has provided a framework for you to be thinking about regional customization of pre-hospital destination plans for acute ischemic stroke. Thank you very much.